Thank you all, and once again, welcome to everybody. We really appreciate everybody who's in attendance, who's come out, whether you're attending online or whether you're here in person. It's wonderful to see you and be able to connect with everyone. I was given this talk to start off with going over some of the premises of spinal endoscopy, as well as go over some practical strategies. And by the way, Mark Mahan, a professor of neurosurgery at the University of Utah. Okay. The most important part is that we're going to try to minimize pain with our surgery so we can maximize our recovery. And the three things that I think about when we're trying to maximize our recovery is to minimize the tissue injury that's involving our adjuvants so that the postoperative pain is minimized, and then we're also going to try to reduce the anesthetic burden that's involved with our spine surgery. And so muscle trauma is the pain. That is the first and foremost. And so the ways we're going to try to do that is to minimize our footprint. I had the delight of about 2 years ago debating Kevin Foley at the AANS with regard to what was better, tubular or endoscopic spine surgery. And you have to give Dr. Foley credit. I mean, he was the inventor of one of the first endoscopic spine systems. 1997, he came out with the MED, right, the microendoscopic discectomy system. And although I say that it was 1997, and Parvitz Kambin had already done that with a 5mm endoscope in 1986. So although we credit a lot of this device as being one of the first systems to be utilized, it was not really the first system for spinal endoscopy, which really got its start in 1990. So his point at that time during this lecture was to say, it's the tube. The tube displaces forces and minimizes tissue ischemia. And I would assume it's because he's trying to compare that to typical retractors. And this is going to really distribute that compressive force, and we're going to get less tissue necrosis. But anyone who's done a tube knows that what you're going to do is make a generous skin incision. You're going to do a paraspinal muscle dissection, and you always have to remove that small chunk of muscle at the bottom of the tube. Right? You can't get away without having the tube that you're going to remove that muscle. And then you look at the volume. So let's say you're doing an 18mm tube, which is relatively reasonable for most, 7 centimeters. Your volume of tissue displaced by your tube is 18 centimeters, more or less. Compare that to an endoscopic spine decompression. You're about an 8mm skin incision for about a 7mm tube. Your muscle resection is minimal. Everything you're trying to do with the tube is to get underneath the multifidus, not sit on top of the multifidus and then remove it. And then you're going to do dynamic muscle retraction the whole time, right? It's not a static tube that's being held in place by a static arm. You're moving through the tissue, so it's never permanently ischemic during the time of your surgery. And your volume of displacement is 3. So the endoscopic tube volume is 15% of that of a standard tubular discectomy. Why do I care about the size of the tube? Because size does matter. That if you look at the bar graph on the line graph on the far right, you see that compared microendoscopic surgery versus tubular endoscopic, you see much less creatinine kinase, serum levels, days after surgery. And by the way, that the postoperative VAS scores were higher in microendoscopic surgery. So you have more urinary and serum muscle breakdown after an open procedure, which is minimally elevated by a endoscopic system. So question that's been mentioned, there's a lot of interest in biportal versus uniportal surgery and very compared to open. This was a study out of South Korea. Similar study, they did a wonderful job of tracking different markers. And so creatinine phosphokinase is on the far left. And you see that the open at 1 day is much greater elevated to 3 times or approximately baseline values right after surgery. And the lactate dehydrogenase, again, was a little bit higher. So what you're seeing is that, and interestingly, uniportal and biportal were the same. There's a little bit of elevation of muscle breakdown, but very, very minimal. Compare that. This was a cervical comparison between open and, between biportal and uniportal. similar findings, that basically these creatinine phosphokinase in the far right, a little bit different between the two, slightly more elevated in the biportal, but not statistically significant, as shown right there. So we do know tube size matters, that minimizing your footprint is less likely to cause an increase in the muscle breakdown associated with the surgery. But I think most people in the room would also recognize it's oftentimes the irrigation, right? That we're constantly flushing out the system as we're working. It's a beautiful surgery. There's no blood, to speak of during the surgery. And so potentially it's that reduced burden of the ischemic, necrotic, cauterized tissue that occurs in open surgeries. There's a bacterial load with open surgeries, right? Because there's permeation of bacteria even in open surgeries that we're flushing out with the endoscope, and there's going to be reduced blood and clotting cascade, which likely leads to lower inflammation and sensitization of the nerve root, meaning that when you have blood sitting on a nerve root, it's causing inflammation and it's decreasing its membrane potentials. It's making that nerve more irritable. Same study that we talked about from South Korea when they compared open versus biportal versus uniportal. And now this is a different measure. If you're looking at the far left, it's the ESR, or erythrocyte sedimation rate, versus the C-reactive protein. Much greater inflammation associated with an open surgery versus an endoscopic surgery, whether biportal or uniportal. It's real. Inflammation is real, and that's really oftentimes our problem in dealing with postoperative pain. Switching gears, let's talk a little bit about how to make those patients go home happy. And this is coming in from how we're doing our anesthetic techniques and what other additional blocks. Many of you know that the most recent common vernacular is really the ERAS, or Enhanced Recovery After Surgery. And it tends to be what everybody likes to say. It's evidence-based, it's multidisciplinary, we have consensus guidelines, and it has been consistently shown when studied, because most of those studies are saying, like, we paid attention, now that we've paid attention, and our outcomes are better, but they improve short-term outcomes. The unfortunate thing is it looks like this. This is from a paper in JNS that shows all the different factors that you need to account for when considering ERAS, right? And that, unfortunately, you look at the bottom and it says continued quality improvement teams share quality metrics and patient surveys and staff input to celebrate successes and identify opportunities for improvement. And what I think it ends up coming as something like this, is that when you try to get everybody on the same team, everybody trying to get involved, becomes much more difficult to do. But let's look at some of the data. So this was a paper that was an ERAS guidelines, multinational group that looked at it. Again, looking at everything they could possibly optimize, every phase of care, every different element of it. And most of it is the stuff we already do. They had an 18-point guideline of what all the different items are. And it's like keeping the patient normotemperative, right? Like they're not chilling the patient, making sure that the patient is positioned correctly, making sure that the patient isn't starving, things like that we do routinely. So I'm not certain that there's a lot of things that we can necessarily apply to what we're doing, and it's a lot of things that are outside our hands, right? So I tend to focus it, and I think these are the things that we focus on is, what can I do without begging anesthesia, right? Erector spinae blocks. I think a lot of us have learned. Ray was one of the first ones that I know of that brought this into my awareness, was the use of a long-acting local anesthetic and the thoracolumbar interfascial plane, or how you describe it. Wound infiltration, very common, doesn't need to be stated much. And then the perioperative and postoperative medications that I'm using. Well, interesting, if you look at that ERAS paper that I just referenced that said that we have 18 different points that we can always hit, they looked at the different sort of loose use of local anesthetics around the area, and they said that intrathecal analgesia, quality of evidence, high, recommendation strong. Epidural analgesia, quality, high, recommendation strong. Local regional blocks, this is where like the thoracolumbar interfascial plane or erector spinae block, quality of evidence, high, recommendation, for whatever reason, they said was weak. Don't know why. It's not clear what they were thinking when they said that, why they would say it's weak recommendations. But for the most of us, we're saying it is a great tool. And there are meta-analyses after meta-analyses after meta-analyses. I selected one that show that outcomes are improved with this. When we look at the data, it says the compared to control, the erector spinae block reduced opioid consumption 24 hours after surgery, lowered pain scores, as you would expect, increased patient satisfaction, decreased postoperative nausea and vomiting, minimized hospital length of stay. And it was best when when done at the level of the operation, not a fixed level. For there's some people who would do an erector spinal block at all level, only at L3, but when you do it at the block level, it tends to have better improvement. Most of these are using 0.5% or 0.25% bupivacaine. However, one study was ropivacaine. So we don't have that's the way that these studies are looked, but you can see overall consistent evidence, meta-analysis again after meta-analysis showing that erector spinal block, there's high quality evidence showing that this is going to improve your short-term outcomes. What does it look like? This is my case from Wednesday. Happen to have the images readily available. It's an adjacent level stenosis case. We're doing a interlaminar decompression. Needles on the pedicle above, trying to get it close to the facet joint. The one on the left is better than the one on the right. And just as I mentioned, after you've done your decompression, I always do visualization of my four-root nerve decompression for coding purposes, that I've done a four-root decompression. One thing to consider when you're looking at you're doing erector spinae block, some would say, like, how do I make it last longer? How do I make it work better? Some people use liposomal bupivacaine, some dexmedetomidine, clonidine as an adjunct may be beneficial. Some make a dirty cocktail with ketorolac, right, Toradol, in the wound to help reduce inflammation. And there's been a recent investigation for an erector spinae catheter, so that keeping people on a continuous infusion with an infusion, like an IV infusion pump after surgery, to help increase the duration, particularly for those patients who are going to be an inpatient stay. What can I do again, right? So in the ERAS, they basically said that every postoperative pain medication had been looked at. You can see on this, it's like nonsteroidals, acetaminophen, gabapentin, ketamine, et cetera, mag sulfate. However, there's no evidence. There's no high-quality trial saying whatever you give after surgery has any differences. So what do? So I always discuss my preoperative pain medication regimen with anesthesia, right? I want preoperatively acetaminophen, oftentimes Lyrica. I ask them not to use a COX-2 selective inhibitor beforehand because it's going to limit what I'm going to give afterwards. I will do the erector spinae block. I'll infiltrate the wound, and at the conclusion of the case, I will use dexamethasone down my irrigation port. Our risks of infection are extremely low, so I feel very confident in most of my cases, except for dural tear, using dexamethasone down the irrigation port. And then I'll use IV Toradol for postoperative. And I find that that is honestly one of the most impressive recoveries. If I get a patient that had a COX-2 selective before surgery and not getting Toradol after surgery, they're very different on their wake up. The IV Toradol is one of the more impressive agents I find. And because what we do this is 98% of patients who are opioid naive stay opioid naive. They're not going home on anything other than ibuprofen and Tylenol. And then lastly, anesthetic reduction. This is constantly a topic. This is not something that we can answer today. What anesthesia technique you're going to utilize? But you can reduce anesthesia, right? These can be done awake or with sedation with local spinal anesthesia. It's great. It's a wonderful way of taking high-risk, high-morbidity patients through surgery by using spinal anesthesia. And some people do spinal analgesia, meaning intrathecal morphine, which helps reduce blood loss in a lot of scoliosis cases, and it helps us in our procedures if you want to. There's good evidence for sedation over general anesthesia. The awake patients tend to have shorter hospital length of stay, sometimes lower operative time, but these are biased comparisons, right? And that they tend to have complication rates that are higher under general anesthesia with greater postoperative nausea and vomiting. So, in summary, minimize your tissue injury. I think everybody's here because of that, because they know that there's substantial benefits from using constant irrigation in a smaller working port. We want to consider, because they're going to decrease that inflammatory load to the system, and it's going to help the patients have less postoperative inflammation, have less postoperative pain, and particularly less neuropathic pain after the surgery. Regional blocks are well indicated and can be a strong add to your armamentarium for postoperative pain control if you're not already doing them. And then having the right regimen before surgery, after surgery, picking the one that benefits to you, knowing that there's no good scientific evidence to push one way or the other. And then anesthesia reduction is certainly, the benefits accrue to those of you who can manage that with your anesthesiologist to reduce the anesthetic burden on your patients. With that, I want to welcome anyone to apply for fellowship in the upcoming year, and thank you.
Double rainbow.
Hey, Mark, that was a fantastic talk. I really, I think bringing it home to things that we're in control of is very, I think very tangible, and we can move ahead. Where do you see the sweet spot for, erector spine blocks? Because, right now you use dexamethasone down the dupe. By the way, what is your dose for that? How much?
4 milligrams total. So if I need to split it, go ahead. Yeah. So I'll split, if I'm doing 2 levels, I'll split it between the levels, but I'll go over 4.
So 4 milligram total. And then when do you do a, erector spine block versus, just infiltrating, doing an epidural lavage?
Say that again, epidural
When
lavage?
you do the epidural, basically pouring down the dexamethasone, the tube is an epidural lavage, I would assume, right?
Yeah.
So when you do that versus injecting, doing a block, a paraspinal block?
So yeah, everyone's getting a paraspinal block. Before the start of the surgery.
With any case? Even at this?
No, transfemoral, I don't tend to use an erector spinal block.
That's a question. Where do you?
Yeah.
What is
so anything interlaminar when you're touching the multifidus. Okay. Though what's interesting is that there was a paper, you may have come across it, where they looked at erector spinal blocks in ALIFs, morphine reduction, improved patient satisfaction. The erector spinal block is just a wonderful procedure, even if the skin incision's on the wrong side. So I don't tend to do it for my transforaminals, but
what you do is for endoscopic limes, or?
Yeah, for everything that's in, it's a paramedian approach, just simply because I know I'm touching the multifidus. But for transforaminals, I haven't found that it adds. When I do it, patient wakes up great. When I don't do it, patient wakes up great.
So I do them, and I actually have a question for you, but I do them on every posterior lumbar surgery now, and my anesthesiologist tells me he can tell when that, I just use Marcaine because it's cheap, 0.5% Marcaine, and it lasts about 8 hours, gets them over the hump, but my anesthesiologist can tell when that Marcaine sets up because they have 0 stimulation on the endoscopic cases. My question for you, Mark, is I noticed that on that endoscopic LAMI you showed that you did bilaterals. So I'll usually, bilateral ESP blocks, right. I'll usually just do the block on the side that I'm approaching from. Do you find that it's helpful to do it on both sides for these endoscopic cases?
Absolutely. I find it's really, really beneficial because I am going to be, most of my cases are going to be, if it's like a stenosis case, I'm touching the contralateral facet. Our goal of decompression is getting that medial facet taken care of and decompressed, and I find that they definitely wake up differently if I do unilateral versus bilateral.
And if you're just doing, say, a discectomy, a unilateral discectomy, you only block, or do you just always just block both sides?
Sure, but what's the additional? I mean, it's the same fluoro shots, it's the same time. I think it works really well, but certainly I can see why you would do one side. When you're doing I don't know how you cut your bupivacaine. Oftentimes I really want to get a large volume block, and I think that's how much volume you're getting in there really does matter too. So it's like a 20 cc volume that I'm injecting on both sides.
And you also do Marcaine or something else too?
I have access to liposomal bupivacaine, which I find works. I mean, some people are 36 hours, some people are 72 hours. Everybody's a little bit different, but it's a different block, I find. Yep. When I'm using, versus like ropivacaine with clonidine.
Different block as it is.
Like a different duration? Different duration of block, meaning that like the ropivacaine seem to be more like a 12-hour duration, whereas the Exparels last a little longer. But it's very expensive, so I can, how much are you paying for that extra additional hour, right? So it's a reasonable question. Great. Dr. Song.